morning, everyone. And thank you for this opportunity to be here. I'm really excited and honored to be here. And I'm excited to have the opportunity to share about advances in the field of pain science. Pain is something that connects us all as human beings. Pain refuses to be confined to a single discipline. It spans our collective professions, and yet understanding another's pain is often elusive. What I'm going to talk about today may be familiar to you. You may be familiar with just how difficult it is to treat persistent pain. And as we'll be talking about pain today, just talking about pain can be enough to trigger pain for some people. So I encourage you to do what you need to do to take care of yourself during this talk. Today, I want to talk about how a shift in our thinking with new learning can help create positive change for people with persistent pain. Incredible advances have been made in the field of pain science, and these are often at odds with the ways that we think as healthcare professionals, as patients, and as society. And pain is not quite so straightforward as it might seem. Some ways that we think about pain may not be conducive to rehabilitation and recovery, or even management of a chronic condition while pursuing valued life goals and activities. Some of the information today might seem jarring to you or contradict some assumptions. And I encourage you to take this opportunity to pause and examine your own beliefs and assumptions, actions and interactions in regards to pain, and notice how this information sits with you. It may also be different from the beliefs of the people that we see. While there's a lot that we still don't know about pain, we do know that a modern understanding of pain helps individuals with their recoveries and helps us to find improved ways of addressing pain on a societal level. People who learn about their pain system and how it amplifies and modulates sensory input have better outcomes. By shifting an understanding of pain as from something that's caused by undetected or uncorrected pathology to protection by a pain system that can become hypersensitive, but that is trainable, people often experience a transformative shift. Multiple RCTs and system reviews have shown the importance and the sustained benefits that come from learning about pain in pain and disability, fear, catastrophizing, and confidence in self-efficacy, as well as increased engagement in physical activity and physical therapy, and enhanced benefits from exercise. This highlights the notion that pain education must be frontline care for people with pain. And clinicians have a profound effect on the way that people think, people's beliefs and behaviors, and on people's level of protection, highlighting the need to share this information widely. To understand how best to deal with persistent pain, it's helpful to recognize the models that we use to think about it. Models consist of ideas about cause and effect relationships, and whether we realize it or not, they shape how we understand pain and inform the choices that we make, such as the advice that we offer, or the interventions we use, or even the language that we use. The dominant model in the West is a biomedical model. To give us a little bit of historical context, prior to the 17th century in the West, pain was associated with religious belief. And during the spread of Christianity in the Middle Ages, pain and suffering were explained in a Christian religious context. The soul became the domain of the church, and the body that of the scientists. In the West, the cultural concept of mind-body duality, the separation of mind and body, is rooted in the church's recognition of the body as separate from the soul and therefore permissible to investigate. In the 17th century, it was thought that the body was like a machine. And for example, something like fire would open a valve in the skin and send a pain signal along a pain thread to open a valve to a pain center in the brain, telling the brain pain. And this theory transformed the perception of pain from a spiritual experience to a physical mechanical sensation, meaning that a cure could be found by identifying those pain fibers. This led to a biomedical model with certain assumptions that pain can be reliably attributed to an underlying pathology, but it's the result of physical damage, such as injury, illness, or system dysfunction. That pain is an accurate indicator of the state of the tissues, and that by fixing the problem, we can alleviate the symptom. If we view pain with a biomedical model, we're likely to seek or provide biomedical interventions. Many investigations and interventions, such as imaging, surgery, and passive therapies, are based on the assumption that pain is an accurate indicator of the state of the tissues and that resolving underlying pathology will resolve pain. For example, the idea that getting a knee replacement will resolve knee pain. In fact, about 20% of people who get total knee replacement continue to have persistent knee pain. Lumbar fusions in the state of New York increased 55% from 2005 to 2014, the amount of annual procedures, and increased 26% within the Medicare population from 2012 to 2017. And other highly invasive procedures targeting presumed structural causes of back pain, such as nerve blocks, ablations, medications, are common. And yet, back pain remains the single greatest cause of years lived with disability. Here's some more fun facts about asymptomatic abnormalities. 97% of people with no knee pain have structural abnormalities. 84% of 48-year-olds with no back pain have disc degeneration. And the severity of rotator cuff tears is not correlated with pain level. A biomedical model fails to explain why disc degeneration, disc bulges, arthritis, rotator cuff tears, and meniscus tears are extremely common in people with no pain. Pain can exist without injury, and injury can occur without pain. It boils down to pain is not a marker of structural pathology. And these statistics tell us that pain is about something more than tissue damage, that tissue damage doesn't tell the whole story. While more useful for acute presentations, a biomedical model alone is not so useful for understanding and addressing persistent pain. A direct, hardwired link between tissue damage and pain is not supported by the evidence. Another problem with the biomedical model in regard to pain is that likening the body to being broken and in need of fixing leads to overprotection. People who are told that their knees or their backs and whatnot are damaged tend to become fearful, limiting engagement in activities that could lead to improvements, losing out on the benefits of movement for health and pain. A biomedical model can lead to over-medicalization of pain, increased utilization of healthcare, and inappropriate use of risky and costly medications and invasive procedures with little evidence of effectiveness over placebo. In an often endless search for an anatomical source, of the pain. If an anatomical source can't be found, an unproductive blame game often begins. Is the patient to blame for their own pain? Or is the clinician to blame for the patient's pain? Is the clinician responsible for fixing the pain? Finally, when an anatomical source can't be found, it may be considered that the pain is psychogenic, or that the person is lying or malingering, leading to feelings of invalidation, stigma, and unnecessary suffering when a person hears they're being told that the pain is in their head or that they're faking it. In fact, people without a biomedical basis for their pain face lower levels of clinician sympathy, disbelief, and mistrust, and consequently, they often experience less positive outcomes. And it is only in the DSM-5 that the last traces of causal language of medically unexplained pain being psychological have been eliminated. However, most, if not all of us, have learned our craft within a culture influenced by a biomedical model, and that gives us pause for thought. Do any of you see people who hold similar beliefs about this cause and effect around an anatomical source? And how might we be influenced by a biomedical culture in regard to pain? It's likely that we all are influenced by it because it's part of our culture. To better understand what impacts pain, we'll go through a brief, super simplified 1-minute overview of nociception. Nociception is the transmission of information about actual or potential danger. Nociception is not the same thing as pain. First, we have a noxious thermal, mechanical, or chemical stimulus that causes or threatens damage, and nociceptors fire, sending a signal about danger to the spinal cord. Neurotransmitters are released from central terminals where they synapse with neurons in the spinal cord that are projecting to the brain, and these send information to the brain, which acts on the spinal cord neurons to inhibit or facilitate ascending input. A network of interconnected brain regions creates a conscious experience of pain based on an overall evaluation of all the information at hand. Nociception can occur without pain. For example, if you pay attention to your bottom sitting on the chair right now, you may begin to sense discomfort due to this process of nociception that's going on all the time, and you may not have noticed that prior to paying attention to it. Pain can also occur in the absence of relevant nociception. Tissue damage can occur without pain, and pain can occur in the absence of tissue damage. Input up to the brain is modulated by a descending modulatory system that can facilitate nociceptive input or inhibit it. This system has extensive connections with brain regions that are involved in attention, emotions, thoughts, and expectations. It has a remarkable capacity to modulate pain according to the competing demands of physiological, psychological, and social factors. Projections from the brain act on pre- and postsynaptic neurons directly or indirectly to facilitate or inhibit nociceptive traffic, changing the experience of pain. So when greater threat is perceived, when greater threat is perceived, the descending facilitatory system ramps up the volume of transmission of the input, as if the brain were saying, tell me more, I need to know more about this danger. The release of neurotransmitters excites spinal cord neurons, ramping up this transmission of danger messages. And this can be affected by vigilance, attention, stress, and negative expectations. When the system evaluates that threat is not so great, the descending inhibitory system, red, there we go, dampens transmission of signals, as if the brain were saying, I don't want to hear about that. I'm interested in something else. So we can see how feelings, thoughts, expectations, and attention affect the pain experience. And negative cognitions and emotions can facilitate pain through these descending pathways. And this is also one mechanism behind the placebo effect. When pain persists, changes occur on multiple levels of the nervous system. And one of the key features of persistent pain is neuroplasticity, or prolonged changes in the nervous system as it adapts, including, importantly, increased sensitivity and responsiveness of dorsal horn neurons. We could think of that as if one message were coming in from the foot and 5 messages go up to the brain. And remember those 20% of people who got a total knee replacement and continued to have persistent knee pain. It turns out that they have altered pain processing, and temporal summation is one way of measuring that. Changes occur in the brain as well as pain persists. And these images here show changes in cortical representations of body parts in phantom limb pain. The actual location of sensory of those body representations shifts. Sensory motor disruptions also occur, and that includes things like a distorted body image, reduced proprioception, reduced tactile acuity, changes in distribution of muscle activation, changes in the way the body feels. And this drawing here was done by a person in a study on back pain and body image. And this person has drawn with these thick lines, show where the person has drawn the part of their back that they can sense. And this section that doesn't have a line is the part that they can't find. The comment is like, I can't find it. And that correlates with the area of back pain in this person. So these are examples of plastic changes that occur in persistent pain. And it's just to give you an idea of the complexity, because we need to have a shared understanding of this complexity in persistent pain. So one of the key messages about nociception is that when pain persists, the nervous system becomes sensitized, and it amplifies and modulates information sent to the brain, meaning that pain is not just a reflection of peripheral input and pathology, but it's also a reflection of plasticity. And plasticity profoundly alters our sensitivity, and it can become a major contributor to many pain conditions. But neuroplasticity also means that pain can change, and this gives us hope, and it also provides us with potential targets for treatment. And although much remains to be learned, it's generally considered that many plastic changes in the nervous system are not irreversible. And the ability of the central nervous system to adapt and change is an important part of rehabilitation and recovery. And the message here is that the pain system can become hypersensitive, but over time and with work, that can also be reduced back to a more normal level. We can better identify contributors to the pain experience using a biopsychosocial model. And this gives us a better understanding of how more than just biological factors impact the pain experience. It demonstrates the importance of not only biological factors, but also psychological and social factors in a dynamic interaction. And we know that pain can be triggered, exacerbated, maintained, or reduced by this interaction of biological, psychological, and social factors. Because the perception of threat can stem from all of these. We can think of pain, we can understand pain as a type of protection from threat. The nervous system is always assessing threat versus safety based on all the information at hand. And often much of this information is unconscious. We're not aware of it. And one way that the nervous system protects us is by producing pain. So pain is a conscious experience that emerges from an unconscious perception of threat, usually in combination with other types of threat, with other types of protection, excuse me. And it's meant to keep us safe from harm. In the short term, these protections are adaptive, but they can become overly protective and keep us from doing the things that would help us to get better. Here are some examples of protective responses when there is perceived threat to bodily integrity. These can interact and mutually influence one another, but they stem from an assessment of a need for protection. And again, long term, these can interfere with recovery. Clinicians have a profound effect on people's beliefs and behaviors and levels of protection. And when healthcare professionals believe that pain is a sign of damage, assuming a direct relationship between tissue damage and pain, and that rest is required, and when clinicians are themselves fearful of movement when there's pain, we pass on those beliefs to patients, inducing fear of movement and excessive rest. And this ultimately leads to poorer outcomes for persistent pain. We're more likely to reinforce fears about pain by ordering imaging, prescribing medications, and referring to invasive procedures. We're more likely to tell patients to rest, to take time off, and to use pain as a guide, which tends to be an inappropriate recommendation for persistent pain. Learning cues can come from overt instruction that we give. For example, be careful about bending, or stop when it hurts. Or they can be subtle, such in our language. For example, with phrases like, it's bone on bone in there. As a result, patients are more likely to hold catastrophic beliefs about pain. They're more likely to be fearful of movement and to engage in pain behaviors such as excessive rest. And they're less likely to engage in movement and activity. So we can reflect on whether we are reinforcing harmful structural pathoanatomical beliefs, or are we promoting self-efficacy and the ability to engage in meaningful activities with our own attitudes, actions, and words. When we understand that pain is not the same as tissue damage, and that pain is about protection from threat, our goals shift from correcting supposed pathologies in the tissues to helping people feel safe. So how can we help people to feel safe? At the San Diego Pain Summit last weekend, I asked one speaker who is a person with lived experience of pain, if you had the opportunity to talk with healthcare professionals across the state, what would be the one key thing that you would want to communicate? And she said, believe them. And it's important to convey, I believe you, through our demeanor and our actions and our language, to a person living with pain. And it's important to listen, to understand their experience. When a patient says, "I'm sorry for going on and on about this, taking up all the time," that's when we want to say, "Tell me more." That's exactly what I want to hear about. Because we can't find pain by looking into the tissues. We need to zoom out and look at the whole person. We need to listen to the narrative and look at the person's interaction with their environment. Then we will have a closer appreciation of what their experience is. And by listening in this way, by listening to understand, by believing the person, we can develop a relationship of trust. And that's extraordinarily powerful in affecting pain outcomes. The language that we use has a profound effect on how people think and what they experience. Here are some examples for food for thought about language that can provoke a sense of threat and alternatives that might promote greater resilience and health. We can shift our messaging from reinforcing beliefs about the body's vulnerability and the need to protect to the body as resilient, giving permission to get on with living without waiting for pain to be gone. On another note, surgery is a very invasive procedure with risks and an extremely powerful placebo effect. What if we gave different messages about the risks and benefits of invasive procedures and alternatives? We can shift our perspective from persistent pain as something to be fixed to navigating a fluid, dynamic journey that will involve uncertainty. For example, we could say, "We don't know what will help you, but here are a bunch of things that seem to help people in similar situations. Which one of these seems interesting to you to start with?" And that already gives agency. This shift in perspective involves making sense of loss and the challenge to identity that a person with pain experiences. It can involve exploration, giving people the opportunity to contemplate their own experience in light of new information, engaging with that information curiously, with curiosity, and self-compassion. And also important is encouraging people to reconnect with the world in meaningful ways. This new understanding also implies a shift in focus from pain reduction to a focus on function. We should avoid focusing on measures of pain intensity because it doesn't improve function. It doesn't improve quality of life. When we focus on reducing pain before moving, a fixation with reducing pain maintains a cycle of a search for relief without getting anywhere. And it doesn't get them moving. It doesn't change beliefs or behaviors. And total pain relief is often not feasible. But a focus on improving function and reducing interference of pain with life leads to improvements in daily activities, mood, self-efficacy, and catastrophizing. And then there's the added benefit of pain reduction. Exercise is the first line recommendation for almost every condition. And it's not a matter of if we should give exercise, general exercise. It's a matter of what and how. And the what is what you enjoy. Naturally, when we don't move, the body becomes deconditioned and sensitivity increases. And it makes sense that people will experience some pain as they begin to move. And sensitivity shouldn't be ignored. People may need help as they nudge into the pain. And build slowly while building confidence. But increased sensitivity makes moving difficult. And that's one reason why encouraging people to adhere to movement practice is as much an art as a science. And I noticed that I'm coming up on my time. So I will just go through some of these slides quickly so that you can view them again on the recording if you'd like, and touch on some important points. But many people with pain give up on exercise and physical therapy. So how do we get them moving when they're fearful and moving hurts? It can involve accepting, which doesn't mean giving up. It means letting go of a pursuit of a cure, making space for pain and living life despite pain. Redirecting effort from controlling to managing and adapting, and making space for things that matter. Making sense of pain, because having a better understanding of pain gives a why of behind strategies. Meaningful, mindful awareness of the body and movement can help people find safe ways of being in their body. And multidimensional interventions that address understanding, assessment of threat, sensory motor disruptions, fear, and lifestyle tend to be more effective. I'll just put up here some such promising interventions that involve embodiment with illusions about strength of the back and size of the knee. Therapy that involves understanding, learning, relaxation, and self-regulation strategies that are put into practice in behavioral experiments and support for changing lifestyle habits, and sensory motor retraining. Also, social prescription, as pain always is an experience of a person in relation to their environment. And social prescription is a concept that's taking hold in some countries. Also, self-management, which doesn't mean necessarily being thrown to the wolves. It can involve getting help from a coach, therapist, or peer support or other support. And there's so many things that we can do to help people with their journey, to understand that pain can change. And here's one example of things that people can do. And I'll finish there. And I'll take any questions.